many of the fields that sometimes we just have access to a little piece of the information, and then that's all that our brain remember. And then in future, in the time, you get maybe somebody else that mentioned something about, do you see this rapid expansion in adults? And they will controversy the point just because what they remember from dental school is say rapid expansion is only working for kids. So the approach that we have with our great speakers, Marianna Evans, who is orthodontist but also periodontist, is what is called non-surgical mid-facial developed in adults, airway, periodontal, all the periodontal implications. So before go any further, let me pass it to Hamid. So we say a welcome to our guest tonight.
Hello, Mariana. How are you?
I'm good. Thank you so much for your presentation.
Fantastic. This has been one of the interviews I've been very much looking forward to as a practitioner that delves both into ortho and surgery. I've been looking forward to this to see what you have and kind of pick your brains so I'm very excited to see what you have to say about us. So without further ado, if you, Javier, you want to do a brief introduction of how you...
So first, Marianna and I, we met, we have the opportunity to be lecturing together at the Academy of Equilibration Society. So then I finished my lecture, I left the room, and then when I come back, the first thing that I seen is a CVCT with like 10, 12 millimeters between in that raphe. And I wasn't even followed, but then when I see that, I was just blown away. I say, what the hell is this? I need to stay. And my wife was waiting for me. I say, no, it's no way that I'm gonna leave this room without knowing what's going on. And for my own look, I didn't even know, but this year in January, I was with the Arnett group in the maxillofacial group getting trained, and one of the speakers was here, but we didn't even connect. We have to go to dinner together, and when we start to say, we didn't met before? And then from that point, after that she made that lecture, I say, everybody needs to know that. Everybody needs to know this, because we always trying to gain airway, and mostly even that we're trying to be a little disruptive with treatments, because like Hamid and I, we normally use expansors prior our treatment. Mostly the expansor technique that we use is conventional 3 ways that is making the movement from the teeth simultaneously, with some benefits, of course, but also with some tipping that is not what we want. And the point that I learned from her is how the body reacts when you make maxillary expansion when you're not holding structures to the periodontal ligament, because it's a totally different response. And that's what you get to that magnificent. So let's hear to, first of all, tell us a little bit about how you make this transition from periodontist to orthodontist or vice versa, and then how you start doing in something that is not common. Don't call it, let's call it disruptive, because it's not a standard care. So let us a little bit about that, and then of course I have another technical questions to engage the audience in what we're doing.
Thank you so much for the introduction. Well, first of all, I started my dental career back in Ukraine and in Moldova, which is part of Eastern Europe. And I always wanted to be a periodontist. When I was a dental student, I wanted to be a periodontist. I come from the family of dentists. I'm a 3rd generation dentist, and I knew a little bit about restorative dentistry when I started dental school, and I always wanted to be a little bit closer to biology rather than mechanics. So I was introduced to periodontics during my education, and I really fell in love. So my first 3 years before I came to the United States, I practiced as a periodontist in Ukraine and doing very minimal surgery, no implants, just periodontal maintenance, getting into periodontics, because we didn't have back then in Ukraine specialty of periodontology as we have in the United States. And I learned very quickly that periodontal health is impossible without proper occlusion. If you compare patients that had a little bit better occlusion to patients that had severe malocclusion, patients with severe malocclusion had very little chance to succeed with periodontal treatment. So occlusion is extremely important for periodontal stability and the healing of the periodontal lesion. So by the time I came to the United States to continue my education in the United States, I realized that I need to know a little bit more about occlusion so I can help patients with periodontal treatment. So I was accepted to University of Pennsylvania Advanced Standing Program in 2005 and 4. So when I started my program, one of the first lectures that I attended was by Dr. Robert Van Arsdal. Dr. Robert Van Arsdal at that time was a head of orthodontic department and also was the head of combined perio-ortho program. And he was also dual trained in periodontics and orthodontics. So he gave this outstanding lecture to the dental students on the link between occlusion, a periodontal lesion, and interdisciplinary treatment. And when I saw his lecture, I said to myself, that's exactly what I'm looking for. So I am going to pursue my career in this combined education, interdisciplinary treatment. And I was very fortunate to get accepted to the combined perio-ortho program at Penn, and it was 2006. And I have to say, one of the very fundamental parts of my philosophy, of my who I am, identity I am today, is came from Penn, from my teachers, Morton Amsterdam, Robert Van Arsdal, Dr. Farshid Sanavi. I had outstanding teachers that were able to
hold that thought. We're going to ask you about all those names. We're going to ask you about all those names. That's coming up.
So I feel like I got some very good foundation for my education, but when I started to practice in 2010, following what I learned in my residency, I realized that not everything is working. Not all the puzzle pieces are coming together. And airway in 2010, 2011 was not on the map in orthodontics and was not on the map in my practice. So after I worked for about 12 months and I started to take some medical history, looking at my cases that I have expanded with traditional protocol, I saw that it's not stable, that something is missing. And I had one patient that I referred to the ENT because we found huge tonsils on the CBCT and clinically, and he was very symptomatic with ADHD. He was a 12-year-old child, and he ended up being diagnosed with severe obstructive and central sleep apnea. And I realized that this was the piece that was missing in my practice, in my diagnosis, and I started to self-educate myself. At that time, we didn't have many courses, if any, 2011, 2010. In this field as we have today, and I think this is where it all started.
Wow, so this is beautiful. Okay, so you bring us back in time, and now so we know where you're coming from with this thinking process. But now the question is, so let's inform the people about what is the procedure that you do, and then I will ask you technical questions. Because of course, after I get inspired by you, we have to try. So with softwares, I develop different alternatives to guide the surgery and stuff like that, that I know that you probably make it way more easier. But let's start with the foundation of the concept. What you're trying to achieve, what is the procedure? I already described it, it's a rapid expansion, but give us a little insight about the process, and then we will talk about the technicalities compared compare with regular orthopedics, that is in the way that I get trained, for instance, to use these kind of devices. So let us know a little bit about how you do it, what is the time. I know that you personally a patient, actually your gap is getting bigger, and then we will talk in general about what is the effects and benefits that we have after all this, what you're looking for.
So basically, I would like to start with the diagnosis. So the reason why we do expansion, and I think the terminology that we have used in the past, such as rapid maxillary expansion, rapid palatal expansion, is a little bit becoming outdated, and it's really not based on today's CBCT evidence reflecting exactly what is happening in human body, in the human face from that procedure. So let's start with the diagnosis. The reason why we are stretching midfacial structures, because it's not just maxilla, we are stretching the midfacial structures of your face with this technique, because midfacial deficiency is one of the most common problems in malocclusion today. As a matter of fact, you will probably not find any malocclusion that has a normal maxilla in shape and in size. So it's a very important treatment if we can address it skeletally, because the problem starts with the bone. The problem ends up at the level of the teeth, but it starts with the bone deficiency. So what we can do with this protocol, we are opening maxillary mid-palatal suture, and also we are opening sutures much higher above the maxilla at the level of circummaxillary sutures. So you are making a change at the level of mid-face, and it is very clinically significant, because if you are going to make this change above the dentition, nasal cavity, which is the entry into your airway, is going to be affected. And it's going to be affected significantly more than we are used to see with the traditional tooth-supported expanders. The reason why, because we are actually using the bone anchors or temporary implant devices to apply the pressure to the bone directly, bypassing the teeth. And when we apply the pressure closer to the center of resistance, closer to those skeletal sutures, we are getting significantly more skeletal correction than we used to get with the traditional tooth-supported expander. So we are changing the midface of human body.
Okay, for a neuroseptic standpoint, how is the stimulation to the bone level in the osteoceptors in comparison with the periodontal ligament? That is something really important that you talk about it, because most people also are afraid to use expansors when they connect it with teeth, because the sensitivity of the periodontal ligament is running in different levels in comparison what has the tendency to create bone loss. That is what people is more afraid to get the teeth out of the ridges, right? So for the scientific standpoint, what you can tell us about that differentiation in the cells and how that process is make it different than just traditional expansors?
So if you look at the histology of the connective tissue in the mid-palatal suture, or any suture of the skull and the periodontal ligament, the only difference that you will find is in the periodontal ligament. On one side, that ligament or connective tissue is attached to the bone. On the other side, it's attached to the surface of the root. Histologically, it's exactly the same connective tissue as you see in the sutures of the bone. In the sutures of the bone, as we see in the mid-palatal suture, that connective tissue connects two portions of the two halves of the bone. So it's bone to bone versus tooth to bone connection. And obviously, periodontal ligament is very it's a sensory organ and it's very sensitive. And when you look at the forces that you can apply to the teeth are significantly weaker than the bones. So that's why in all the patients, when you have a increased surface area of the interdigitation in the suture, where you have to apply significantly higher forces to open that suture, the teeth cannot withstand those forces, and the teeth are going, even if the patient doesn't feel a lot of pain or sensitivity in the tooth, the teeth are going to expand beyond of biologic envelope of what is biologically acceptable for the tooth to be in the bone. So the teeth are weaker than that mid-palatal suture in all the patients. That's why every single paper that you see in orthodontics in all the patients after adolescent growth spurt is recommending to involve either a surgery or skeletal anchorage to expand when we choose to put orthopedic forces on the bone, because orthopedic forces are not for the teeth in all the patients. So there is a significant difference in terms of what tooth can tolerate before the damage is done and what the bone can tolerate to respond to the stimulus. So we want to get away from pressure on the teeth.
Yeah.
I'm sorry. When you place these implant retained expanders in there, do you also start or pinpoint to get the process started in the mid palate, or?
So we find, and my experience might be a little bit different from other clinicians that are doing it on a regular basis today, but we find that there is a significant difference between female and male adult patients. So far in our practice, we have not, there was no need to do any type of adjunctive stimulation of the bone with perforations in females. And the oldest female that I have treated is 64. And I am treating a lot of females older than 40 with this approach. So females so far opening without additional surgical intervention. On the other hand, when we talk about males, and I honestly, personally, looking at the CBCT data that we are collecting, find that it's a lot of it has to do with the nasal bones and sutures in the nasal bones and maxillary nasal complex. So we find that male patients older than 25 have less chance of having that non-surgical bone opening. Do we try? Absolutely, we will still try in any male at the age of 35, but we have not had a single male under the age of 25 that failed to open, and we did not use any surgical cortipuncture stimulation. But older than 25, the statistics are changing, and there is much less chance for the male to respond without any surgical intervention.
What about patients with mid-sized to large torus?
Mid-palatal tori?
Yes.
We find that mid-palatal tori is not as much of a problem as we might think. So mid-palatal tori still is opening. It could be a problem for the fit of the appliance, but not for the sutural opening in females, at least. Okay. Possibly in males.
So that quality of that bone for that exostosis doesn't create a more difficult vector or pattern to break with the expansor?
We have treated many patients with palatal tori when it comes to females. So I would say that it was not an interference for opening of the palate. In males, I didn't treat that many males with palatal tori, so I don't have the answer. But if you want to have like evidence-based answer, I don't think we have the answer based on the literature, because this is very new concept.
So do you think that the women respond better because the amount of elastin and collagen, just because the women are developed to open the pelvis to birth, and you think that has
There,
some influence?
I think there has to do some hormonal components to this ability to open the sutures of the skull. I think this might be the new area for not just the dental or orthodontic research, but for medical research to really understand the difference between the female and males in terms of their bone physiology and how the hormones affect the sutural remodeling. So I think there is definitely something hormonal, I think. And I have been speaking to the medical doctors that know a little bit about bone physiology and the hormones, and there is definitely agreement and on that part that there has to be a hormonal response difference between females and males.
Okay. Now let's talk some little bit about mechanics and devices. Again, since I saw you, I went really interested. So I've been looking for different kind of devices. I found different references, different vectors of forces. Is one that has like a little hinge into the back, have like a movement. So create an expansion into the front, but the posterior is more conservative. I found something, so another one that goes connected to the first molar with bands. So I assume that they're doing a connection. Let's start with that differentiation between components before we start talking about the vectors of positioning and the anchoring direction. Because again, all this, I just, after I saw, I came back to the computer, I said, let me see what I'm gonna do. And I start checking in the CVCT. Amir and I, we laugh, we kind of try, but we were afraid to turn it in the way that you do. So we're gonna have three topics that we're gonna talk. Let's talk about these two devices, or classification of the elements that you use for the disjunction. Then we will talk about the position that we place it and the position of the vectors when you're gonna make the anchoring, because that's what we've been all struggle when we want to try just in the first attempt, you know?
Yes, so there are, I have to say that the vectors and the devices, it's kind of one topic because there are several devices available to us today, and they have different vectors of force application. So one of the devices that we are using in adults is a device called MSE. It's maxillary skeletal expander by a Korean biomaterials company, and it was originally developed by Dr. Moon from UCLA. So this device includes 4 implants that are placed in the palatal floor, or the right parallel to the mid-palatal suture along the same plane. And it also involves 2 bands on the upper first molars that are connected to the expansion screw itself. So it's not completely tooth-free appliance, it's a combined skeletal and tooth-supported appliance. And the benefit of this device being used in adults is that the screw, activation screw, is actually hex. So there are a lot of force that is required to be applied to the bone in adults to really open those mid-palatal sutures. That's why we have some evidence with our cases where the screws may fracture, or the screws may bend as a result of failure of the mid-palatal or circummaxillary sutural opening. So there is a lot of force being applied, and it's better to apply this force to something, a device like a TAD that can fail, rather than to have the system fail, such as biologic side effect and periodontal failure. So I think this is one of the devices that we use in adults. The benefit is that the implants are placed very close to the mid-palatal suture. The downside is those bands on the molars. So if you have a patient with weak periodontal support, those molars are going to tip. They are going to come a little bit outside the bone. And that's why we try to disengage the molars as soon as possible into the expansion process.
Oh,
And
but you start with the connection with the molars first, and then you cut it.
yes, and
You
then
always start with them. You never place it without the molars engaged?
I think in patients under the age of 25, you don't need the molars engaged. I think in patients that already had sutural opening, where you are going for the second round of expansion, I think those patients also don't need the molars engaged. But today, we really need more data to kind of compare different groups to answer that question, and we don't have the data to answer this yet.
No.
The second type of device is something that oral surgeons can do. It's called KLS distractor. And this device requires incisions on the palatal slopes in the area of insertion of those side bars. It's a little bit more invasive device, and could be significant tissue impingement and inflammation associated with it. But it seems like it's working as well in some of the oral surgeons' hands that have been using this device. The third option is utilizing acrylic pads with the 4 implants or 2 implants, depending on the age of the patient. And we actually cover this very thoroughly in our courses. Basically the implants are placed in the palatal slopes, and they are secured to the screw with a special composite material called triad putty that you use for your custom tray fabrication. You connect acrylic to this triad putty, and there are several variations of this technique that you can utilize. But the implants are placed in the palatal slopes between the roots of the teeth. So the bone is a little bit softer in those areas. And the vector of force is actually much better than in the MSE device. The problem is that because you apply axial force to those implants, however, the implants are farther away from those sutures that we are trying to open. So you won't be as successful opening those sutures in adults as you will be in young adults and in adolescent patients under the age of 25 and under the age of 18. So I think there are many options to utilize this protocol, many techniques, and you really need to have many tools in your toolbox to really get that process going and get a good result.
Right. In our limited experience, we used the last one, the last model with the acrylic pads and implants in the slopes, which is exactly that experience that I had. That especially the distal implants got loose very quickly, and I found that they were not putting as much pressure on the suture as I wanted them to do.
This device is really designed for younger patients under the age of 18, or in adults. You can use it as a second or third expander to just fine-tune expansion to finish widening once your sutures are already open, but not as the device to open the suture in adults.
Okay, that's what happened. I mean, you see how we learn. We're here for learning.
We live and we learn. That's it. The mesial implants did well, and we did accomplish a good amount of expansion on that. It was a 50-year-old female patient, and it did happen. But that brings me to another question, doctor. Most of this we're talking about lateral expansion, and as you the first thing that you mentioned, the mid-face deficiency, always makes me think of the sagittal. What are we to do with that sagittal deficiency? What do you do?
Yes, so this is based on my experience and evaluation of multiple CBCTs of treated patients. You cannot really separate horizontal deficiency from the AP or the sagittal deficiency. If you're talking about maxillary hypoplasia, it's one problem. Maxilla doesn't shrink this way and this way. It shrinks three-dimensionally.
Mm-hmm.
So the word expansion or expanders that we use in our field is associated just with horizontal expansion is not right. Because if you are going to do proper expansion for the maxilla, just by opening the mid-palatal suture alone, you're going to have a significant AP change in that maxilla. But there is a threshold that you have to surpass to get that AP correction. So there is enough evidence in the literature that just from opening the mid-palatal suture in all the patients, there is a rotation component to the maxilla where it will rotate up to 1.5 millimeters forward. So they're going to be in very mild AP or class 3 cases, improvement in the class 3 or AP deficiency of the maxilla. But if you just take a patient that has midfacial deficiency, and sometimes it seems to you that there is no AP, almost all the patients that have transverse deficiency have AP deficiency. And as long as you do the proper opening of the mid-palatal suture, you're going to affect maxilla significantly in AP.
So it does still glide forward. It's not just this way. So it's not just lateral, but it's a glide and opening forward as well.
Like an umbrella.
Like an umbrella, like a accordion, like an accordion. So definitely, when I look at my patients where we do the non-surgical AP correction versus expansion alone, I think most of the AP correction without surgery happens from sufficient opening of the mid-palatal suture. So if you open that suture just a little bit, you only see changes at the horizontal level. But if you open it enough, and there is a formula that can be applied how to do it to get more AP correction, you're going to see a significantly more change in the AP as well.
Correct, but the amount that you open also is somewhat limited with what we have on the bottom. So on the upper arch, we do have this chance of now, with these tools, to open quite a bit. What do we do on the lower arch if it is also rather than...
Yes, that's a very good question. So if you look at today's evidence, the evidence that we have on the relationship in terms of proportions between maxillary deficiency and mandibular situation is that, interestingly, the narrower the maxilla, the wider the mandible is going to be. So patients that have the bilateral crossbite have wider mandible than the patients that don't have a bilateral.
True, I agree.
Usually there is a dental compensation at the level of the mandible to compensate for the maxillary deficiency. So if you look at the CBCT, the only way to do it right is to actually do the virtual setup and uprighting of the mandibular dentition like you do on the articulator for your restorative case. So you have the virtual setup of the mandibular teeth to the proper inclination, and you will be surprised how much you actually can change maxilla to fit with the mandibular dentition. So I think it is a little bit also misunderstood, that relationship, because the only reason why the mandible is going to limit you is if you don't decompensate the teeth properly, and if the mandible is severe class 2. So severe class 2, the mandible is severely deficient in AP. That means that sometimes the mandible has to come forward with the surgical intervention. Otherwise, the mandible is also as moldable as maxilla in transverse is moldable at the level of the teeth with uprighting.
Thank you.
Now let's talk about positioning. Because also that interact different in the way that we make orthopedics in kids, right? So what is the placement when we're trying to work in kids? We want to go a little more anterior with the device, like we put it in like the inclination in the area into the canine area. I see in most of these devices put it more in the posterior area. What can be the perfect spot to have the screw by itself, because we know that the extensions in acrylic or the arms or the bars is still deflecting a little bit of the strength of the device. So what position you will see need to be the main force, to which level?
You mean, I didn't understand the question very well. You mean the position of the screw?
Yeah, the main screw, because this is where the force is more. You put it behind the papilla, like the area near to the canines, and then, or you put it in the area, bye, mama. Or you put it into the area near to the premolars.
Yes, so it depends on the patient. So the beauty of this approach is that some patients have more deficiency in the front, so you try to place that screw a little bit more in the anterior area, and some patients have more problem in the back. So you have flexibility, and it's 100% customized approach for each patient. So you can place it a little bit more anteriorly, you can place it in the center of the maxilla, which in my opinion is ideal in terms from the front to the back of the maxilla. Or sometimes you place it more posteriorly, but it depends where the problem is the most pronounced.
Okay.
So that's where we place it.
Now let's talk a little bit about the activation timing. That was what was more blow me away, because so I'm doing expansion in my daughter, and in orthopedics we make like one turn every 2 weeks because we work with a concept that is called presence. We just want the bone move away physiologically, getting away naturally. Here, just can you share how much is the activation, because it's quite a lot. But also I want that you talk about that what you extend into the screw is not necessarily what you gain into the bone, and how you reset the appliance. Remember, I have the luxury to see you twice, so I just want that in this little conversation we don't lose the main points that catch my attention.
Our questions, and we're coming down to the last 20 minutes.
Okay, so last one, and then we'll start with the formal part.
Okay.
Sure. So the activation is a very important question to discuss, because we are talking obviously about skeletal immature patients. Skeletal immature patients do not have fusions in the facial sutures, that they have increased interdigitation of the sutures, where it is going to be required more force to open them up. So the activation is different to open those sutures and to widen them. So there are two stages to expansion. One stage is opening of the sutures. Unlike in children, the suture starts opening with the first turn because the sutures are open. In skeletal immature patients, you have to stimulate a little bit more the bone to open those sutures. And once that bone opens, then you can slow down. So if it is somebody like adolescent patient between 12 to 18, we start with one turn a day. And once we see like 0.5 millimeter of increase in the diastema, you can slow down to 2 turns a week, 3 turns a week. So you don't want to open large diastema. You want to get away from the rapid expansion protocol. You want to slow down. And this is the tendency today in the whole profession, is to get away from that rapid protocol, because the rapid protocol will open large diastema and it's going to take slower to heal, and there could be some rebound. So we want to slow down the process. In adults, it could be 4 to 5 turns a day, depending on the screw. Each screw has different amount of opening in the screw. Like for example, a traditional expansion screw has approximately 5 turns to open it 1 millimeter. The MSE is different. It will require like closer to 7, 8 turns. It's 6 turns to achieve 0.8 millimeter opening of the screw, so that's different. So what we find that in adults, we also customize it, and we would open the screw the day of the procedure up to 6 to 8 turns to stimulate the bone until the patient feels something in the bone.
Wow.
And then you slow down to 4 turns a day, 2 in the morning, 2 at night, until the suture opens. Once that suture opens, you can go down. Well, it's not always happening like that in adults, but sometimes you actually fracturing the bone. In some situations, the patients really feel like the bone is fracturing. So you want to be gentle. You want to calibrate each patient to what they can tolerate and what the bone requires. And once that suture is open, you can do 2 turns a day. One is usually not enough.
I actually can understand that logic, because that screw, I was thinking about that, is the strongest at that point that you place it on up to about 28 days. At that point, it's actually going to be looser than the day that you put it on. So if you go slower, it's possible that later
nothing will happen.
Correct.
Yeah. So there are 2 things that you have to remember: is the screw. Actually, 3 things: the screw, the bone that we are trying to open, and the implants. So you cannot go too slow in the very beginning, because remember that your implants, the rules that apply to your traditional dental implants in terms of primary and secondary stability apply exactly the same to the temporary anchorage devices. So you are relying on the primary stability of those implants to achieve that sutural opening. So if you're going to go slow, and within 4 weeks of going slow, the implants are getting weaker and weaker. So you're applying more forces to the teeth or to that screw. So there is very high chance that the bone is not going to open at all. So you have to be more aggressive in the beginning, as long as your implants are stable. And then
there you go. That's the other mistake we made.
Yeah, you see. But I have another question, Hamid, but we cannot end up with the gap open. Now we need to find out how we're gonna close the gap. So honestly, we're gonna get tired. So tell us now, and I'm sorry, I know that I'm squeezing you, but I want your brain here. So then you break and you create a diastema. To which point you start making the centros to start getting together? Can you combine those forces? And if you do, what can be the more ideal way to do it? Can you do with just simple braces and elastics and start moving one at a time, or you have solutions?
It's just a control arch type of mechanism, isn't it?
So interesting is that, you know, if the periodontium along all maxillary teeth is healthy, you have something that we call transeptal fibers. Transeptal fibers are those types of periodontal fibers that are responsible for the arch integrity, or they connect all the teeth together. So as soon as you stop turning the expander, those transeptal fibers are stretched, and they are going to bring those teeth together. And so patients that did not go through the surgical expansion protocol, they show diastema closure even without putting the braces on within a month. That diastema will start closing. And so much faster. Our recommendation is light, minimal forces applied to the teeth throughout the whole treatment, any orthodontic treatment that we are doing. That's biologically the healthiest thing you can do to that periodontal ligament. So there is no contraindication from placing braces right away when you go through this process. But you definitely do not want to put any A-chains or elastics to start actively close the diastema. The role of the braces and the wires is to guide the teeth. So as you are allowing those transeptal fibers to bring the crowns of the teeth together, the brackets and the wires are keeping the roots upright. So I think we need to do more research in orthodontics, how via closing those big diastemas, especially after orthognathic surgery. And I think some of the answers that we see based on our clinical data, we have very little research on closing diastema after expansion from periodontal standpoint, is that if you wait too long to close that diastema, the bone that is going to be filled between those central incisors is dense cortical bone. And there is nothing worse than moving the tooth through the cortical bone. This is a risk of root resorption, and it's going to be a significantly slower process than moving the tooth through immature bundle medulla bone. So I think besides needing more research in the area, I think do not put heavy forces to close and force the diastema close as soon as you can. Try to guide the teeth. Try to focus on getting the diastema open. Monitor when the diastema starts opening and then slow down so you don't open large diastemas. So you let the biology close the gap as naturally as possible with minimal forces applied.
Fantastic.
Beautiful. Now I can breathe. Now all yours, Hamid.
All right. All right. Now we're going to get to
by the way, this is my diastema.
Yeah, that's what I was saying. It's growing.
I have my expanded. This diastema did not get bigger than this.
Marianne,
So,
I'm gonna show you mine.
Not bigger diastema than this.
Oh, I got double on both sides. I'm moving this segment forward, so it's very in today. You know, don't worry about it. All right, we're gonna get to the question and answer.
Okay.
And since you made a reference at the very beginning about your interest in occlusion, that's where we're going to start, Marianne. Tell me, what is occlusion to you? And of course, you did tell us the name, but you said them too fast. My second part of the question was, who were your influences? That's what I was. We're gonna write them down.
Mm-hmm. So I know that there are a lot of philosophies and concepts about occlusion. Even until today, and I'm only 10 years into this, next month I will celebrate 10 years since I graduated from my residency. So I'm very new to this. I'm still learning to this. So I have to say that occlusion for me is maximum intercuspation. It's stability for the joints, to minimize the muscle activity, to minimize joint loading. So the teeth have to provide that stability with allowing maximum intercuspation. So when you look at the ancient occlusions, before we saw crowding and malocclusion that we see today, when we had wear of the dentition, there is one thing that is common in what is considered acceptable occlusion today, physiologic, and what was acceptable at that time is having as many contacts as possible. So I am not sure if where the concept of canine guidance or a lot of other concepts in occlusion come from. Occlusion is a very difficult area to study. But I have to say that as an orthodontist, as a periodontist, I want two things. I want to have maximum number of contacts between the upper and lower teeth. And I also
does that mean the maximum number of teeth in contact also?
Yes. Well, we are talking about the integrity, so I assume that we have the full dentition.
Full set of dentition. Just want to set it for the record.
So I want to have maximum intercuspation. I want to have minimal muscle activity. So the system works with minimal effort. You cannot separate teeth from the joints and the teeth from the muscles.
Thank you.
And I also want to have the teeth in the bone. I want to have axial loading. So if you ask me what I believe, what is for me the most important as an orthodontist, as a periodontist, is to have teeth in contact throughout the arch, from the back to the front, light contacts in the front, a little bit stronger contacts in the back, and every single tooth should be axially loaded. That means there should be supporting bone circumferentially around all the teeth from the front to the back, from the mesial to distal, to allow that axial loading and that force to be transmitted directly to the rest of the facial skeleton. So that's what is my goal in my treatment.
Fantastic.
Do you consider cervical spine and airway as a part of the definition of occlusion, or just independent components that they don't get tied together with occlusion? What is your thought about that?
I think you cannot, the only thing that is separating these elements is our specialties. But we are talking about one system. So you cannot separate the nasal cavity from the oral cavity. You cannot separate the cervical spine from the head of the patient, from the airway. So I think it's all related. And I think the key is to allow, even for the cervical spine, the most natural posture allows the axial loading of the spine. So we want to create if we have to address the problem, we want to allow that axial loading of the spine. We don't want to have the forward head posture where the muscles are basically holding the skull. The spine should be holding the skull, supporting the skull, not the muscles.
I guess what we're trying to ask is that, do you believe that different type of malocclusion or correct occlusion can have an effect on the cervical, on the integrity of cervical spine?
And mandibular position, because I think they both go related.
I think we have to remember that malocclusion, the way it presents clinically, is adaptation to some kind of malfunction. So a lot of malocclusion will be a form to adapt to the forward head posture. So it's very difficult in one individual patient to separate where is the chicken, where is the egg, but it's all related. And it could start with the head posture, with the cervical spine. It could start with the respiratory apparatus, and it could start with the oral apparatus. So I think there are so many different variations and combinations that the patient may present with, and it's always multifactorial, but I think there is no question that malocclusion is adaptation, and it could be the cause of other components of the system being more susceptible to break down, because that malocclusion can only solve so much of the problem in terms of the level of adaptation. So I think it's very complex. It's not a simple answer to your question.
Yeah.
Okay. Second question, Marianne, is which factors do you consider prior to stabilization of your patients? You know, such as same things as we talked, like posture, airway, you know, things of that nature.
So we look at I feel like I still am not where I want to be in terms of my comprehensive treatment and treatment planning and diagnosis, but we definitely consider the breathing. We definitely consider habits. We definitely consider postural components of functional side to our patients and what we can help them with. But for me, I think the way I think and the way I see looking back at our results is that if the patient has a problem, it's a vicious cycle. And we have to intervene and break that vicious cycle, vicious circle of problems. So my belief is that you have to start with the structural correction. If somebody has a dysfunction, when it's postural, when it's breathing, you want to obviously address the breathing, but sometimes it's impossible to address the breathing without addressing the structure. So we are very lucky in orthodontics that we can change the maxilla. Unlike mandible or any other part of your head, maxilla is the most moldable structure in adults and in children. So maxilla is the foundation of healthy respiration and healthy oral function. So we have that opportunity to set that maxilla right in adults and in children. So that's my focus. So we set the foundation, we set that maxilla in volume, in size, in shape to what it should be in a natural environment as much as it can. We can do it, correct it. And then we start addressing the function around it, because a lot of times that function will self-improve after you address the maxilla. And a lot of times patients need additional help. What I don't believe is right is start working with the function when maxilla or the bones are deficient and there is no good foundation for that system to work in axial loading mode. So for me,
By function, do you mean oral myofunctional therapy to start?
or like tongue exercises, myofunctional therapy, unless it's just strengthening exercises, I think sometimes it's impossible to get a good result unless you change the structure. So I think it's a very difficult question to answer because we need more research to see what works the best. But you cannot separate function from structure. And my philosophy is if the structure is so easy to fix, when it comes to the midface, let's fix the structure first and then erase the old memory, because the muscles are attached to the structure. So you change the structure, you erase the old memory of the muscles, then you have a better foundation to reteach those muscles how to function better.
No doubt about it.
I love the spaghetti test, by the way. The spaghetti as the exercise. That was so amazing. No, she put a video of her daughter doing the spaghetti test. And that's
yeah?
really, really cool. I put my daughter just to watch it. Now I need to do spaghetti tonight. So, yeah, she asked me, I want to do that. So, okay, next
Marianna,
question.
which type of information or diagnostic records do you take at this point?
So we take the videos of the patient.
Videos.
We take a lot of pictures of the posture, of the face, of the bite, and of course we take CBCTs.
Okay.
And bite registration.
Bite registration? And habitual bite, or their
Treatment
normal
position.
maximum intercuspation, is that what we're taking?
We take habitual bite, we take CR. There is still a place where you need to know where a CR bite is.
Okay, I think we're going to need another hour for you to explain which CR we're talking about.
So we take a lot of registrations of the bite to see where the patient starts with.
Fantastic. But your main radiographic is basically a CBCT because you have the whole picture. Excellent. All right. So now I think that aside from the CBCT, are you guys using any other instrumentation? Do you ever take MRIs looking at the joint, soft tissue, or
Draw tracking?
Not on the regular basis, but in patients with some joint pathology we do. And we are very fortunate in our facility where we work that we have a very nice imaging center where we can refer our patients.
That's nice.
MRI.
All right. How about jaw tracking or kinetic movement or chewing cycles? Do you guys check any of that?
I don't check them.
All right. How about interdisciplinarily approach? Do you guys ever work with PTs, chiropractors, or other? You probably work with some ENTs or some sleep physicians, correct?
Yes. So we work in our practice with myofunctional therapists. We work with allergists, ENTs, sleep physicians, and some chiropractors that are focusing more on the TMJ and spine and also neck, cervical musculature. So we do work, and we are very lucky in our area that we have a few of them that have completed courses on restoration breathing, and they are a little bit more knowledgeable about the whole system.
That's fantastic.
Mm-hmm.
Okay, so next we want to talk about the sequence of treatment. What is your normal sequence of treatment after your workup?
Mm-hmm.
Can you delve into that? Are you guys looking for a specific functional trajectory, or even for vertical?
Mm-hmm. So our sequence of treatment depends obviously on the patient, but when
Generalized. I mean, you don't have to be specific.
you mean my sequence when I start the treatment, or just in general?
In general, when the patient comes, you look, you say, okay, this maxilla is deficient, and this is how I have to go forward.
Mm-hmm. So if the patient is asymptomatic in the TMJ, that they don't have, they might have some structural changes in the TMJ, but are asymptomatic, have reproducible jaw relationships, have no pain at when I check the seated joint position. So I think those patients are ready to go through the skeletal and orthodontic reconstruction. So we do not, if that maxilla is deficient, there is nothing that I start with but with maxillary correction. So we start with expansion. If there is a joint, active joint breakdown, if there is an active joint disease where you see resorption, you see that the patient is symptomatic, then you have to start with the joint. I do not start any orthodontic treatment on symptomatic patients on the TMJ end. So we start with correcting the structure. If they have a tongue tie, the tongue tie is addressed after maxilla is expanded and they start myofunctional therapy. If they have any type of the airway problem, then we work on those patients with the team, with allergy specialists.
Now, during this time that you're making the expansion, in order to break down the engaging of the occlusion, because the occlusion relation can be a limitation to allow the proper expansion.
Mm-hmm.
How are you disengaging the teeth? Are you putting a removable appliance, or you making build-ups on top of the posteriors to break down and just allow those teeth to don't be engaged into the occlusion so they can move faster?
Well, if there is a real problem with occlusion, usually we use the composite buildups. We do not do any removable appliances during expansion.
Okay, that's important. Okay,
We
great.
can theoretically use the bite plate in the mandible, but we try, the expansion process is already a challenge for the patients everyday life. So we try to be as simple as possible. So we try to minimize the number of appliances, minimize the responsibility of the patient to wear something additional, and make it as simple as possible. But in a lot of patients that it may look to you that occlusion is locking, once you start expanding, the occlusion will simultaneously start changing. So not all the patients that are going through expansion need to be disarticulated with the buildups.
Oh, okay.
It's a very dynamic process.
All right. I'm gonna modify the next question. Normally we ask how much of a factor is facial aesthetic in your treatment, but I'm gonna just ask you that how much of a consideration it is to you when you start, the facial aesthetics to you when you start the cases.
Mm-hmm. Well, facial aesthetics is, you cannot separate it from your whole treatment plan. It's part of it. It's part of the puzzle. And facial aesthetics are used to evaluate maxillary deficiency, to evaluate the vertical relationships between the jaws, to evaluate AP relationships. So I think we before I do any diagnostics on the patient, we start with spatial aesthetics, just visual
So
evaluation.
from the beginning,
From the
you're
very beginning,
considering.
it's part
And
of it.
does that, I'm sorry, does that include incisal display and
Oh,
gingival display?
absolutely.
All that.
Absolutely. So we do three-dimensional treatment planning and treatment. So it's part of the whole diagnosis. And if you address, so for us, the goal is to address the bone as much as we can. If you address the bone, the teeth will be in a better place in the end. So the whole case will look better from the aesthetic standpoint. So sometimes you have to do intrusion when the teeth are over-erupted. So I
Fantastic.
think you do have to do a digital smile design as part of your comprehensive treatment planning protocol.
Perfect.
Good. You
All
see,
right.
we have more things in common than we imagine. Good.
All right. Now we go to question 8, and it goes back. Let's go back to that case you were talking about, that the patient was symptomatic in the jaw joint, and you take the CBCT and you see some bony changes, let's say degenerative disease on one of the condyles. Have you worked with any of the growth factor injections into the jaw joint for rehabilitating these or remodeling these into a healthier state? Have you heard about it? Have you any experience with it?
Yes, I have zero experience with the growth factors injections into the joints. My part in managing the joints involves in terms of fabrication of the bite plates and stabilizing, giving the patient a little bit better occlusion, temporary occlusal scheme to let the joint heal. I also work with some oral surgeons that will be more likely to utilize those biological injections for those patients. And I think we have to remember the joint is, temporomandibular joint is a very adaptive organ and has a tremendous potential to heal. Sometimes it takes a little bit longer, but I probably will belong to those clinicians that are a little bit more conservative with the joint and allowing it as much naturally to heal as possible rather than jumping into the surgical interventions. And
We're not talking about surgery here. We're just talking about introduction. It's just an injection. Yeah.
Yeah. And I have not tried any of the injections. I'm very curious to learn about all these options, but I definitely think there is a place for this therapy, no question.
Perfect.
Do you think that we can benefit to inject growing factors into the suture to speed up the healing of the closing? No, because that's why we're here. That's a question that is who better than her to answer that, right? What do you think? Can be crazy or can make sense?
You mean after the opening?
Yes.
It increases the blood supply.
Just mention something. I think Mariana is frozen.
I think so.
It happened with mine a few minutes. Okay.
So I'm interviewing you now.
No, but how fascinating! Let's do some comments about it.
It was great. It's great. So I hope we
She's
get her
frozen.
back for the last few.
She's frozen. So I don't know. Yeah.
I'm afraid.
So I think was really valuable information. I think was really good to offer another alternatives in general, the utilization of these devices. And also look for another alternative because honestly, in many cases that they compromise big time sideways, and then patients they don't want to go for regular expansion or treatment. And I think this became to the side that is like an invisible orthodontic. So I think this one is a good space for these kind of devices. And I'm wondering how we can incorporate setups to do it combination with clear aligners that I think can be great to be able to predict. So I hope she come back. Part of the question that we did that eventually we definitely need to take courses more about this. But my thinking process is how with clear orthodontics now we can start making the setup to try to move those teeth. What can be a good rational sequence
We
to
have
start
two,
making?
don't forget, we have two cases right now in process that we have done the surgery and activation of the bone, and we are going through that movement with the aligner. So I will tell you in 4.5, 5 months how those cases are looking, and if that movement has happened. Although not mid-palatal, we did the decortication in these cases, going through and through. So we are doing some things, but certainly I can now see what was our mistake with the other case with the mid-palatal suture. We should have gone a lot faster, and the patient would have probably been more comfortable, would have gotten that thing off sooner.
Okay, so I don't get an answer. Nati, do we have any answer? Okay, so in the meantime, let's see, we hope that she connects, or we can say thank you for this amazing.
Yeah, that would be.
Honestly, I think we couldn't squeeze her more. I feel bad, but it was so amazing, the information. So I think anyways, we need to wrap it up. So what else we can say to everybody? Thank you so much to be here. Tomorrow is going to be a great day. Let me tell you what we're going to have tomorrow. Tomorrow we're going to have Dr. Lucas Lasman from Poland, an amazing, I think the youngest guy that is doing.
I don't think we're going to finish exactly in an hour on that one. I feel like a lot of good discussions are coming up.
Yeah, he's amazing, and actually he's doing such amazing webinars as well. The beauty of him is he's fully trained in the physical therapy side, and in his clinic he has this as a regular part of the workflow. He's a full-time physical therapy in his office, and the plan, the workflow that he has is just really, really amazing. Of course, also we have many things in common. I will say he follows the philosophy of Dr. Coyce, and we want also that he explained us a little bit about that connection between the craniocervical stabilization by Dr. Rocavaro and how they implemented now with the stabilization phase into the bite to the Coyce, the programmer. So I'm really willing to have him. Plus that also he has a beautiful. Here we go.
I don't know what happened. We got disconnected.
Well,
Okay.
we're happy that you're back. Thank you so much.
Okay, so let's speed up the question, Hamid, and
All
then.
right, so we're getting to the end. Mariana, in reference to your finished cases, do you ever notice postural changes after your treatment? Positive, negative, unexpected, expected?
Mhm. Yes, sometimes we see positive changes in the posture. Sometimes we don't see much change in the posture. So this is a very interesting area for research, for discussion, but posture is definitely a multifactorial problem. And I think orthopedic correction of the bite in a lot of the situations will add to the improvement of the posture, no question about it.
Fantastic. All right, so how about Javier? We skip number 10 because I don't know the philosophical approach to teaching of the different occlusal philosophy in the school.
Why not? Let's just try to rephrase the question. Do you think at some point we're gonna be more everybody into the same page into the occlusion? Because still we have too many things in common, but still we have significant differences between philosophies. That is a fact. Do you think that eventually we
actually,
can
I think, yeah, there is, I'm sorry to jump in, but actually I think there are common points there. Like you mentioned that you do think that the cervical neck is involved. You do think the airway is involved. You do think the head position is key. But we're not getting any of that, even things that we seemingly agree on, taught enough in schools. Do you foresee even maybe addition of some of those in schools?
Mm-hmm. I think with more understanding of the importance that the airway health plays in facial development and overall health of the patient, I think we will not be able to ignore the role of the cervical spine, posture, and breathing in dental education. So I think the future is about interdisciplinary education, care, and research. So I think it's going to get more integrated than it is today. But how quickly it's going to take place, I'm not sure. But there is definitely, with the awareness of about sleep apnea and airway today, there is no way back. There is absolutely no way back.
Thank you. All right, Javier.
Maybe we'll have it for the kids. Yeah. Yesterday, I have my little one over here.
I'm going to let you go with your beloved question 11, Javier.
Okay.
This is Javier's pet peeve. So.
No, it's just that basically the conception for occlusion for many people. So this is a question that they kind of mandate people is asking about these events of rotation and translation into the joints. What do you think? Do you think that they combine effects? Do you think that the joint make the rotation initially, as some of the literature explain? Do you think that is a translation, like many of the new evidence with new equipment? We can see some of those changes. What do you think about those dynamic movements inside the joint?
Mm-hmm. I think based on my understanding from the clinical side and from the literature, the majority of the function in our joint is happening at the level of rotation. Maybe I'm wrong. Maybe I'm wrong, but I think the system is there is nothing more intelligent than our system. It's the problem how we understand it and how much we learn about it. And we are also limited how much we know. You know, we are dentists, we are used to see the tooth and we understand how, you know, it relates to the surrounding structures. The joint, we don't see with direct vision. So a lot of the science about the joint is based on how we understand. So now with all these additional imaging options and dynamic imaging options, I think as we learn more about the joint, we will be able to understand it more. But I think a lot of the questions about the joint today are still unanswered.
Yeah, that's why we trying to get more people with the ideas.
Brings a good point on, Marianne. Do you really think then that we should have a different education perhaps about the joint because we are dentists? Maybe we should have other professionals that are really experts in joints, such as PTs or even chiropractors, telling us about, or as part of the curriculum, even in the schools, teaching us about the kinetics and the movements in the jaw joint.
Mm-hmm. I think yes, there is no question that the more integrative we can do interdisciplinary education, the better it is for us to understand. But I think that one of the problems is that limitations of the available research on the joint today. No matter
in
how
dentistry.
much,
in dentistry.
In dentistry and even in other fields, I think they might be studying the joint from their end, but there are some things that they are probably missing because they are not looking at occlusion. So I think the key is to really design some very good interdisciplinary research to be able to teach exactly what is happening in the joint. That's, I think, for me, a start. But there is no question that we can learn a lot about the joint and the muscles from the physical therapist.
Now, the little final part of the question, and then we end up is, so how is your occlusion scheme when you making the cause-causal relationship? What is your favorite combination? Are you looking for cause-causal relationship? You're trying to get for cause interdental space? What would you consider that can be the best relationship to create a more stable occlusion?
So when I do my orthodontic treatment planning, my goal is to axially position the teeth in the bone. So in 99% of the cases, it requires some skeletal correction of the maxilla to achieve it. And so once I axially upright, every single tooth I want to be uprighted in the bone, to have as many contacts with the opposing tooth as possible. So I want to have what we call more like a tripod type of contact between the upper and lower teeth. That's my, I don't want like the contacts to be slope against slope. I want a more tripod kind of effect.
Are you loading? Are you?
Canines, as you remember from my lectures, my maxillary canines, I need to be maxilla wide enough to allow interproximal space between the roots and to allow tucked in canine position. I don't want my canines tipped out.
Okay, but let me ask you something. In your final positioning, do you believe in recreating the curve of Wilson and speed, you know, a moderate, normal anatomic amounts of curve of speed? The reason I ask is that I've spoken to orthodontists and they flat told me they don't believe in that. They go for a flat plane because they like how it looks, and the word that they use, I'm going to tell you, they call it socked in. They like a socked in because that looks really great. But from our standpoint, we look and we say, hey, there's not enough freedom of movement there for the lower jaw. What do you feel about that?
So this is a very important concept, but again, when you look at them, right now we are studying one of the largest collections on human pre-industrial skulls is actually in Philadelphia at the University of Pennsylvania Anthropology Museum. So we are studying those pre-industrial skulls and how the dentitions were functioning and how the skeletal structures were relating to the dentition and occlusion. And we want to have maximum intercuspation between the teeth, whether it's worn dentition or the dentition with minimal wear. But the freedom in function is very critical. So what you are saying is very important. So a lot of times in orthodontic mechanics, you are, toward the end of the treatment, you're going to put A-chains and you are uprighting the upper front teeth too much, and the bite between the upper and lower anterior teeth is too tight.
Too tight.
So that's not good. So I think the relationship between the molars where the occlusion is nicely sucked in is great, but there has to be sliding, freedom in sliding in all possible directions. So you have to have that. So I don't know about, I like minimal curve of Wilson because I like my occlusion to be uprighted as much as possible. But the more uprighted the occlusion is, the less tight contacts are in the front, between the front teeth. And the more freedom in lateral and sagittal movements you will have, the more inclined the teeth are to compensate for the basal bone skeletal discrepancies, the more you're going to have the sucked in tight bite that is not going,
doesn't allow for freedom.
Will not give you the freedom. So there has to be maximum intercuspation and has to be freedom in movement. I love freedom in centric. I don't want to have this one locked
Correct.
in.
So you're looking for that cusp fossa connection. That's what you mean, maximum intercuspation, not necessarily everything and all the angles and all the what we consider class 1, class 2, class 3 interferences, as we have learned in natology.
So orthodontic treatment, and especially finishing stage of orthodontic treatment, is very dynamic stage of treatment, and it relies on the PDL. So toward the end of orthodontic treatment, we are introducing a functional component to finishing, such as chewing exercises that allow the teeth physiologically to settle. So instead of just pulling the teeth with A-chains and rubber bands to settle, we introduce chewing gum exercises so the patient, the whole system will settle the teeth. All we are doing with wires and brackets and orthodontic rubber bands, we are guiding the teeth, but the forces and angulation of the jaw movement will settle the teeth into the functional maximum intercuspation with freedom in the lateral movements. But that will not be possible unless you properly expand maxilla.
Beautiful. We don't gonna abuse you anymore, honestly.
Thank you.
Thank you so much. Has been great. Actually, I will see, when you were not connected, we make a little review about everything and how we really benefit with this and how we have be able to have answered those questions in a customized way and be able just to make the key points of what it catch my attention in personal and then try to create a full development for this. I can tell you that you have an amazing information and we're really, really looking forward for those 30 minutes lecture because that is going to be amazing when I get able to see it. I'm lucky that I was able to see it, but I definitely want other people to get engaged. So Marianna, thank you so much. I hope to see you soon. I hope everything is going well with you and your family. And thank you one more time for this amazing
Yes,
time.
Marianna, thank you so much for making the time with your family and all to be with us for this hour. You were very gracious with our answering all our pet peeve questions, and it gave us a great small piece of your experience, and we appreciate that. Thank you so much.
Thank you for the opportunity. Thank you.